Good afternoon and welcome to today's IAC webinar, The Problem with Endovenous Overablation and Need for Accreditation. My name is Kelly Baer and I am the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will monitor questions throughout the presentation and try to answer as many of them as possible during the Q&A period. Also on the left sidebar is the Resources tab. Click on this tab for a link to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during this webinar, click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the SVU CME credit, you must be registered, logged into this webinar, then complete the survey. The survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this computer on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. And now I would like to introduce today's guest presenter, Dr. Marc Passman. Dr. Passman is the Professor of Surgery at the University of Alabama at Birmingham. He currently serves as the Director of the UAB Vein Program and UAB Vein Clinic. Dr. Passman is a board-certified specialist in vascular surgery, practicing the full scope of vascular and endovascular surgery. He is published in numerous journals and has co-authored evidence-based guidelines for the management of vascular disease. He is a past president of the American Venous Forum, and for 6 years he served as a founding member of our IAC Vein Center Board of Directors and was involved in the creation of the IAC Vein Center Accreditation Guidelines. And we are happy to have him with us today. With that said, I will now turn this webinar over to today's speaker, Dr. Marc Passman. Doctor?
Well, thank you, Kelly, and I appreciate the opportunity to speak today. Just to apologize, I'm just getting over a cold, so hopefully my voice will hold solid, or at least sound sultry and a good radio voice during this webinar. I appreciate the opportunity to discuss what's really become a big problem within the U.S., and this is this concept of overablation, or more globally termed over-utilization of procedures. So part of this interest, and maybe the reason in part I was selected and invited to speak today, is just some of these publications that we're seeing more and more of. I wrote a similar article here that we'll cover today during the webinar on the problem of overablation. Another area more recently is with iliac vein stenting, which is receiving increased attention from overutilization standpoint. And you see an article here that is a good reference from Endovascular Today. And if you step back to when I was president of the American Venous Forum, I gave a whole presidential address on this, because this whole concept of overablation and overutilization really goes much deeper. It goes into concepts of ethics and professionalism and deviations of that within the medical community. And just to share a little vignette, and this is not untypical of some of these patients we have come see us in our clinic. I had a young 35-year-old who recently gave birth, and afterwards had some spider veins around her ankle area. And she was fairly concerned about that, and went into a vein clinic in our community here. And she was told that she better get those spider veins taken care of, because if she doesn't, she'll eventually end up with a venous ulcer. And, oh, by the way, she'll need 6 procedures to do it, 3 on that leg and actually 3 on the other leg. Although she didn't have any issues with the other leg, she on ultrasound had some concern for venous reflux, really in both legs. And that they could start next week, and they would spread it out every week. She would come in and get the procedure done until it got taken care of, the ablation side. And then they would do some sclerotherapy on the spider veins. Well, she thought that sounded a little aggressive and a little bit beyond what she was looking for, and was somewhat uncomfortable with that recommendation. So she came to see us in our clinic. And we looked at her, and effectively she had few little spider veins around her ankle. But when we ultrasounded her, her ultrasound was absolutely normal. And all she was looking for was not procedure. She just wanted the little confidence that she was going to be okay. And unfortunately, that story does represent some of the problems that we seem to be running into with this concept of overutilization. And a lot of this interest was sparked by this New York Times article in 2015. This article was more specifically focusing on overutilization in the arterial circulation. But within the article, they had this nice figure there where you could see the arterial circulation, the coronaries, the periphery. But then there was hidden in this article kind of this curve with veins going up precipitously over the same time period. And these venous procedures, if you look at the source of the data, came from the Medicare fee-for-service procedures performed from 2005 through 2013, where you could see that peripheral vein revascularizations was up 73%, but this vein ablation category really exploded up 586%. So that's sparked a lot of interest, not just on the arterial circulation, but also within the vein side as well. And more recently in the Wall Street Journal this past September, there was another sort of informative article editorial on doctors sounding an alarm over leg stent surgery. And while this article was a little bit more focused on arterial circulation as well, there was quite a bit of inference over on the veins side. And in fact, one of the studies that they quoted, the group from Johns Hopkins, and we'll look at the article in a little bit, recently looked at sort of this overutilization within the vein population. And if you look at some of these publications, there have been several that have come out in the last year. This was one of the more recent ones in Journal of Vascular Surgery, Venous and Lymphatic Disease a few months ago. And this looked at just a time period of 2017 using a Medicare-based database. During that time, there was 102,000 or so Medicare beneficiaries who underwent endovenous ablation. 96% of which had 1 to 5 ablations, but there was 3 to 4% or so that had more than 5 ablations. And there was a very small group that had greater than 11 ablations. And that really is quite a bit of ablating. And if you look at the providers providing that care, those ablations, represented almost 2,500 providers. And the average, which you see on the graph there, the average ablation per patient was about 1.6. But if you look 2 standard deviations beyond that, you would come up with greater than 3.4 ablations, of which 106 providers, or 4.3%, were providing that. So, and that's represented in red on the curve as well. So, really about 5% or so of providers providing even more overutilization or overablation. Some of the independent associations with the statistical measurements there were these providers represented specialties other than vascular surgery, few years in practice, and just had a higher overall ablation practice volume than the rest of the providers in the registry. So this really gets to the core of what I think is the problem, and it's a challenge to the ethics and professionalism of us as medical providers. And just to give a little bit of medical ethics 101, the general principles of medical ethics requires that there's autonomy, and that is that the patients have autonomy of thought, intention, and decision making with regards to the healthcare procedures. That decision making should be free of any coercion or suggestion by the provider based on what might be important for the provider. It should be focused really on the patient, and that the patient understands all the risks and benefits of the procedure and the likelihood of success. There has to be some degree of justice where the burdens and benefits of new or experimental treatments are spread equally among all groups in society. And that healthcare providers, as distributors of these procedures and treatments, are fair in their distribution, especially when resources are scarce and there might be competing interests or other obligations within that. There needs to be some degree of beneficence, and that is that the procedures are provided with the intent of doing good for the patient involved. And that this requires that healthcare providers are skilled, knowledgeable, are updated in their training, and understand the individual situation of the patients, and together strive for benefit for the patient. And that there's non-malfeasance, so that the procedure that's being done doesn't cause harm to the patient or others in society. So those are the basic principles of medical ethics and really form the core of what our decision making should be. So contrast that with the patterns of inappropriateness. So this is not just overutilization of procedures. It's how you get to that overutilization. And these are the patterns that you see in some vein centers across the U.S. When you look at the documentation, there can be exaggeration of patients' leg complaints. There is documentation of non-operative measures followed. As many of us know, the insurances require oftentimes a period of non-operative measures be tried, and failure of non-operative measures before procedures should be performed. But if you look at the documentation, it looks like these non-operative measures are being performed, but in reality, they're not. Misrepresentation of exam findings, that is that the exam findings are made to be much worse than they really are. Ultrasound exams that are very focused, take 5 minutes to do, with the intent purpose of finding disease, of finding reflux, with a tail wagging the dog, meaning that if you find it, we'll treat it. But if you look a little more deeper at these ultrasounds, they're often incomplete. They certainly don't fall within the IAC guidelines for vascular lab testing. And then some of these extend beyond where there's actual falsification of the ultrasound results. That is, that there's documented reflux where none exists. Some centers provide financial incentives to ultrasound technologists to find reflux. And then even more concerning, we'll use scare tactics with patients to push the operative correction. When you see a pattern of multiple endovenous ablations on the same leg, 3, 4, and then also on the other leg, that's a warning flag, and especially when these multiple interventions are staged. So when you bring this all together, this is really borders on being predatory on patients, taking advantage of their fears, their concerns, and providing procedures for the net benefit, not of the patient, but of the financial gain of the provider. And with that in mind, you're starting to see elements of fraud and providers being addressed with these fraudulent practice patterns. And these are just some cases that you can find that are current, but certainly when you look at curves and you look at Medicare databases and insurance companies, they know where the outliers are. And if it's Medicare will send the FBI in, Department of Justice, and they'll look at these outliers and in the process, look at a lot of these charts and look at a lot of these practice patterns and determine if there is indeed fraud. So what are the reasons for overablation? Well, the number one reason is the financial gain, and it's the financial gain of the provider. If you look at the way ablation's reimbursed, it's very favorable, especially if done in an outpatient setting. And this is just the estimated average for ablation across the country. Usually in the $2,000 to $3,000 range, but sometimes can go higher, sometimes can go lower. And the way the financial reimbursement is set up is if it's done in the office gets the entire reimbursement, as opposed to if it's more hospital-based, where it's split into technical and provider-based fee, and much smaller fee for the provider. So certainly some financial incentive there. And with that in mind, when the ablation came out in the early 2000s, we started seeing an expansion of outpatient centers there. And if you look at today, just driving in small town USA or any town in USA, you don't have to drive far before you see a bulletin board that's advertising varicose veins, or go through a shopping mall and there's a vein center in the shopping mall. So there's really been an explosion of vein centers around this overutilization and parallel to this overutilization. Well, what drives this also may be specialty related. As we saw in the article previously, there's a lot of different specialties performing vein procedures. And if you look at this other review that was published this past year, also in Journal of Vascular Surgery, venous lymphatics, this was a retrospective analysis also of the same Medicare provider database. It was just a little bit different time period. The last study was 2017. This was 2012 to 2014. And it represented 405 plus thousand endovenous ablations provided by almost 6,600 providers. Again, the average ablation number per patient was about 1.6. And you can see the distribution of different specialties on the chart right here, with a dashed line showing that 1.6 ablation per patient threshold, and how different specialties aligned with that. And certainly, if you look at the odds ratio of ending up with an ablation procedure, it was higher with an odds ratio of 3.3, and those trained in fields other than surgery, cardiology, or radiology. 2.6 for services performed in the outpatient setting versus an inpatient setting. And then for high volume providers, you had a greater rate of ending up having multiple ablations. And in this study, this is also Medicare database, just a little different time period, but again, looking at the same source of data. This was 2012 to 2015, 341,750 patients with almost 620,000 ablations, representing 10,000 providers. So if you look at some of the data from this, you can see the growth in patients and procedures over that time period, and some regional variation. For whatever reason, in the South, you're more likely to end up with ablation than a few other regions of the country. And then if you look at the specialties, the pie chart shows that about 28% or so were vascular surgeons, about 20% general surgeons, about 25% cardiologists. And then there's a large other group that represents a wide range of different specialties, some of which aren't trained as part of that specialty in venous disease, meaning that they picked up the skills afterwards. And if you look at the ablation by specialty rate, certainly much higher in those in the other specialty groups than vascular surgery, general surgery, and cardiology. Then if you look at the annual average of ablations per patient per specialty, also much higher in that other group compared to the standard general surgery, cardiology, or vascular surgery. And then if you look a little more closely at those performing greater than 2 ablations, which is a standard deviation or so past that mean, again, it represents about 5% of all the providers. So it's a small group, you might say, of bad apples that represent this overablation, overutilization problem. So that's based on specialty. There's also, if you look at educational courses specific to venous disease across the country, there is a wide variety. There are some very high-end courses that provide very balanced information and present good decision-making and along those lines. But there are also other courses and other organizations that come in and promote the concept of overablation, the concepts of maximizing dollars, the concepts of taking advantage of patients for financial gain. And you have to be careful with that because certainly, from an education standpoint, if you do the wrong thing and know you're doing the wrong thing, that's an ethical issue. But if you do the wrong thing because you were taught to do the wrong thing, that's just an education issue. So you have to be careful with some of these educational courses. But I think part of the problem is reflective of the fact that some of these courses do promote overutilization. What about evidence-based guidelines? Well, there's certainly several venous evidence-based guidelines out there. And what are evidence-based guidelines? Well, they're created by experts in the field. It's based on evidence review, and the quality of evidence is then rated with a recommendation made and a strength placed to that recommendation. It really all comes down to being a framework for clinical decision-making. They're not end-all, say-alls, but it's a good start point for when you make decisions. What they can sometimes be is represent standard of care, but not always. And in some regards, they can represent appropriate care. But in reality, when care is provided, in certain clinical scenarios, although you might start with an evidence-based guideline, the appropriateness extends really beyond that. What they're not set in stone. They're not medical legal. And although insurance coverage plans use them, they're not really meant to be used to determine insurance coverage. I would refer you to several good sources for evidence-based guidelines. The American College of Chest Physicians has like the thrombotic DVT type guidelines. But for varicose veins, the Society for Vascular Surgery and American Venous Forum have guidelines on varicose veins that was last published in 2011 and are currently being updated, and venous ulcer disease published in 2014. If you look at those guidelines, these are what the guidelines say, that for patients with varicose veins, endovenous thermal ablation is safe and effective and recommended for people who truly have saphenous-based reflux. And that endovenous ablation type operations are preferred over open surgery, and that the ambulatory phlebectomy performed if there's varicose veins. For patients with venous ulcer, again, endovenous ablation is supported to improve ulcer healing and prevent recurrence, and should be done in addition to and complementary to compressive therapy. Now, the guidelines are a little bit dated. They don't include some of the newer techniques, but certainly form a base of that decision. On a side note, I know we're talking about ablation, but for iliac vein stenting, this is the next area of overutilization, and we've seen an explosion of this as well. Same practice pattern, same flaw in ethics and professionalism. If you look at the guidelines here, there are, for venous ulcers, benefit to performing angioplasty and stenting, but that's the only area that really has shown to have evidence-based guidelines. For non-thrombotic issues, there's no current evidence-based guidelines for iliac vein stenting. That said, there certainly is need for better evidence. The MedCAC meeting MedCAC is an advisory committee to Medicare for policy coverage determination. There was a MedCAC meeting specific to venous disease in July 2016. I was actually at the meeting, which is a very interesting thing to attend, especially in the government and politic realm. What was interesting about the meeting, it's a small group that actually hear all the data, hear different presenters. But if you look at the actual group, most of the group is made up of public health experts, some in the cardiovascular realm, but there were very few venous experts. And in fact, only one MedCAC member has specific experiences and specialization in venous disease. The rest in red were guests. So very few actually had venous expertise. But that said, what was interesting about it was they posed questions to the MedCAC committee regarding various venous disease scenarios. And these are the two general categories. So if you look at the first scenarios, for adults with varicose veins and other clinical symptoms or signs of chronic venous insufficiency, what they asked the committee is, how confident are you that there's sufficient evidence for an intervention? And they looked at intermediate time periods and then long-term health outcomes. So if you see the set of bar charts first, that was the confidence of the group. Again, 15 people voting. So if you take someone with varicose veins and has symptoms, the confidence in the immediate group was actually pretty good. But if you get into those without symptoms, or certainly in terms of long-term health benefits in both groups, the confidence then starts shifting to very low confidence. And the bottom question was more chronic venous thrombotic and venous obstructive problems, but similarly a low confidence based on the evidence that's out there. So with that in mind, one of the things that came out with MedCAC is CMS and Medicare, struggles a little bit with the current evidence and really needs more evidence to help make coverage decisions. So that's the basics of the problem of overutilization, dissected across different categories. So how can we improve this? How can we make change happen? Well, I'm going to propose a few areas that I think need improvement. And while there may be a need for evidence-based guidelines or better evidence to support what we do, there certainly is a need for appropriateness guidelines. As I mentioned before, evidence-based guidelines provide a nice infrastructure for decision-making, but appropriateness guidelines are those that are specific to clinical scenarios. So applying an evidence-based guideline to a clinical scenario, how appropriate is that for that particular scenario? So because of that, it brings in more than just evidence-based guidelines. There's clinical expertise, patient-centeredness, there's resource use and equally distributing the care across the appropriate populations. There was an interesting article in Bain Magazine 2016, co-authored by Dan Moynihan, Ellen Masuda, and Bob Kissner. And what they approached was, we recognize that there's a lot of inappropriate care being provided. And they highlighted several different areas. And really, for those providing vein care, really the call to action was to make a pledge. And the pledge includes areas as such. So ablation procedures will be performed only on truncal veins associated with established symptoms and signs of venous disease. So symptomatic patients who have truncal axial reflux. Ablation procedures will only be performed when imaging confirmed reflux is documented in the truncal vein and with the appropriate symptoms and signs. So you need ultrasound to accurately document the reflux for that to be appropriate. Truncal veins reflux should be treated with a single procedure for each named vein. So not this concept of multiple procedures done on the same leg at staged settings. and that ultrasound technologists should not be financially incentivized to find reflux, and that sclerotherapy or phlebectomy of varicose veins should be performed by the treating physician who does the ablation, either at the time of the ablation or as a planned future treatment. And there's different scenarios why some should be done at the same time and some should be staged. So this article, this pledge, was more of an opinion piece, but at the time reflected the fact that there was a lot of concern for overutilization, and that it really cuts to an ethical dilemma, and that we as providers should pledge to provide good ethical care. What that has evolved into, though, is actually creation of appropriate use criteria for venous care. And as my role when I was president of the American Venous Forum, along with our leadership at the time, we put together a multi-society project that not only represents American Venous Forum, but other vested societies within venous care, to come up with appropriate guidelines, appropriate use criteria guidelines. And the concept here is that there are scenarios that are presented to a group of experts, and that they use a RAND UCLA method to rate the appropriateness of that scenario. So it's on a 9-point scale. So 7 to 9 would be considered appropriate, clearly appropriate, where 1 would be clearly not appropriate, or what you would say a never event type appropriate, and 2 to 3 rarely appropriate. And then there's a big gray zone in between, which is the 4 to 6 range. I guess it's yellow zone here, but certainly in some situations it might be appropriate to provide the ablation, but not always. So there is certainly some degree of variability within that group. I can't provide you the entire AUC document yet. It's being reviewed right now for publication. But to give you a little advanced example of what the process produced, this is an example of one of the clinical scenarios. So this would be a symptomatic patient presented with various degrees of reflux as described in the first column there. And the question is it appropriate to do ablation? And this just shows the voting grid. And you can look at various degrees of disease, C1, which is spider vein, C2, varicose vein, C3, swelling, and more advanced C4, 6 disease, and how the voting panned out. So, for example, if you take the first number there, great saphenous vein, axial reflux with saphenofemoral junction reflux, and someone with C4 to 6 disease, most, if not all, found that to be appropriate, with a 7 to 9 rating, mostly voting 9. On the other hand, if you take number 6 in this column here, someone who has no reflux, and look at the voting across C1, C2, C3, and C4 to 6 categories, most of the experts found that never to be appropriate. So with that information, then you can create appropriateness scenarios as part of those appropriateness guidelines, which can clarify a little bit where the ablation might be appropriate or might not be appropriate, or maybe very appropriate or never appropriate. So this document will be published later this year, and we can share more with it at that time. But just to give you an advanced view of that, that's in the works. Well, there's also, if you're going to address this, there needs to be attention to quality care. So quality care requires that you track your data. And the Vascular Quality Initiative is an example of one venous-based database that can be used for varicose veins. Vascular Quality Initiative actually includes both arterial and venous disease, but they have a varicose vein module. They have an IVC filter module, and we just finished up the iliac vein stent module, which will be released later this year. But the idea here is to look at quality data, benchmark it against other similar institutions, and to have a process in place to improve quality. If you address quality, then inappropriateness and overutilization, which represents poor quality, should never be part of that equation. What about the need for provider training and credentialing? I mentioned earlier that there's lots of different courses out there, some of which provide good venous disease education, some of which promote some of this inappropriateness and overutilization. Problem out there is if you look at guidelines for privileging, and this is just an example as a vascular surgeon, guidelines for vascular surgeons. This was published some time ago. But if you look more specifically at the document, there's really not much in here on venous disease, except to say that, if you're going to do some venous procedures, diagnostically, 25% should be venous, 75% should be arterial, and that there should be some numbers of venous duplex scanning. But there's nothing in here about endovenous ablation. Similarly, as a surgeon, if you go to American Board of Surgery site, there's really nothing here either to provide credentialing criteria. Now, the American Board of Venous and Lymphatic Medicine gets much, much closer to this. Now, the thing about the ABVLM is it's not recognized by the Board of Medical Specialties. It's sort of an independent board right now, but they do provide basis of education and certification criteria that does elevate the education to a level of appropriateness. A lot of what's in the ABVLM document was actually incorporated into the IAC vein center credentialing document as well. So there's a little bit of parallel there. And so this is a good source for information, and for those that want to seek extra board accreditation, recognizing that it's not recognized by the Board of Medical Specialties, but still provides that infrastructure for education and credentialing. Clearly, if you look at insurance coverage plans, there's a lot of variability out there. I think a lot of the problems with insurance coverage and at the vein center level is you have to meet these criteria. But if you look just within Medicare at the LCDs for different Medicares across the country, there's a lot of variation. And this nice review by Hal Welch, published in 2017 in JVS VL, kind of outlines that problem and sort of the need to codify and more universally define a national coverage plan. And I know there's been some work in the background to try and, with some of the medical societies, work with CMS to do this. But this is important and really, really needed to help solidify the basis for the coverage plans. There certainly needs to be patient awareness. So if you look at patients, buyer beware sometimes. You have to educate yourself before you get a vein procedure done. You should certainly educate yourself about the provider performing that procedure. And so for patient awareness, there's stuff out there in organizations like Choosing Wisely, which provides some warnings and areas for patients to think about. And there's a website here. But, for instance, avoiding routine ultrasounds in patients who just have spider veins. The diagnosis of pelvic venous congestion just made on CT or MR without clinical correlation. And then be aware of the patients who tell you that you need a vein procedure on the opposite leg to prevent varicose veins from developing. So some of this is starting to get into the patient realm a little bit. And then Improving Wisely campaign for providers. This is actually based on the data on the Johns Hopkins paper I showed earlier, where they sampled the Medicare database for 2017. And this is where the two standard deviations past the average rate of was actually 1.6 ablations per patient is the warning sign. So what Improving Wisely did is they sent this data they pulled out of Medicare to each individual provider. And it's kind of like guilt by, hey, why am I an outlier on the curve? It's to increase awareness. Hey, listen, you're performing ablations 2 standard deviations beyond those of most of the other providers in this country. So that it's kind of an indirect way of letting that provider know that, gee, maybe you should look at your practice pattern. You should look at the quality care being provided. And then lastly, just to get into the need for vein center accreditation, and this ties back to IAC. Again, the mission of IAC is to improve healthcare through accreditation. Having participated in the IAC board for vein center, when we created the document, we had to really define quite a bit here. And you can pull all this up. It's in the PDF that's on the IAC vein center site. But certainly, the goals here was to establish minimal requirements for facilities to provide high quality care, establish and maintain standards that govern accreditation, and to be for IAC to be the final decision maker regarding applications for accreditation. The way IAC works in the process is they have created the standards, and that they will accredit all facilities who perform the venous treatments to make sure that they're in compliance with venous standards and all federal state regulations. And then the establishment of quality benchmarks based on resources, training, and outcomes. A definition of a venous treatment facility is any center where venous evaluations, management, and/or treatment procedures are performed. And the standards are the minimum standards required for accreditation. So it's where the bar is set, but it's set to include, not to exclude, but in the process to identify areas where centers can improve their quality. And of course, there's compliance with all federal, state, and local laws and regulations. The primary requirement is that a vein center should perform at least 2 of the 4 following procedures: sclerotherapy, ambulatory phlebectomy, ablation, and non-operative management of those with chronic venous insufficiency and venous ulcers using compression therapy. There must be a protocol in place for other vein problems that may present to those vein centers, and this could be things like SVT, use of accredited vein ultrasound testing facility, then treatments for patients who may present with DVT or arterial disease or other complications of treatments provided at that vein center. The vein centers can have secondary capabilities, but not required for accreditation. And that could include operative stripping and cutaneous lasers, ultrasound-guided foam, and perforator ablation. The IAC document defines what is required of the staffing, and this extends from the medical director to the providers, the ultrasonographers, to the staffing, and it's all outlined in the document. Some space requirements that are important, and some of this seems obvious, but is not always applied, and that's why the accreditation document helps with simple things like hand washing. Equipment, instrumentation, making sure that there are appropriate elevations of equipment that are maybe needed if problems occur. Making sure that the duplex ultrasound follow IAC or ACR guidelines and accreditation. That appropriate medications are available, and that if it's a center that provides or uses fluoroscopy, that proper radiation safety is in place. There certainly needs to be a minimum amount of procedures from a volume standpoint to maintain proficiency. And this is 75 cases per year on average, 25 per category, and at least 2 of the 4 categories. And the centers need to keep a case log. Part of the procedures that's required is that there's good documentation of the clinical evaluation. And that includes photography, ultrasound, reproducibility of ultrasound images, and then SEEP and venous clinical severity scoring. That procedure documentation includes specifically clear documentation and indications that there's a pre-treatment evaluation, and that outcomes afterwards are followed and reported. Other things, like the informed consent process and how you sedate the patient and emergency protocols are all part of the IAC document. From a quality standpoint, there needs to be efforts at quality improvement. Facility must have at least every 6 months a QI meeting, and that should include some degree of peer review and discussion of complications. And part of that discussion should include the appropriateness of procedures, any technical issues that come up, and improving the technique used in that clinic, patient safety issues that come up, if there's incomplete medical records, and poor outcomes. And all those complications should be discussed in some capacity. Interestingly, with that process and such, insurance has taken note. And if you go to the IC website, you can see that there are several insurance carriers across the country now that are requiring IAC vein centers certification, recognizing that it does create a standard for the vein centers, and hopefully in doing so will reduce the overutilization to some capacity. And as of this past month, this shows the distribution across the country. There's been 212 facilities that have been granted accreditation, a lot more on the East Coast than the West Coast, and that may reflect the insurance requirements. If there's a listener out there in Montana, Washington, or Oregon, or North Dakota, or South Dakota, you could be the first in your state to have accreditation. So in closing, the whole concept here, overutilization is a big problem, and it needs to be addressed in several manners. But usually, and importantly, I think what the IAC Vein Center offers is you can get this bay where there's really no water, create some standards that really elevates at least all the boats to a much better place, a much better standard. And then in doing so, over time, that bay, that level of water can be increased and raised to make it better and better over time. So in closing, call to action for all the listeners out there is you need to recognize the problem that there is overablation, overutilization of procedures. If you are a clinic that performs a lot of ablations and a lot of ablations per patient, especially following some of the patterns we talked about before, I would call you to look closely at your practice patterns and ask yourself, am I providing appropriate care? And certainly if you are a center that is providing appropriate care, I would ask you to elevate that even further to provide even higher quality of care. And whether it's through IAC or other mechanisms, there's opportunity there as well. And even for myself, just to share, we're IAC accredited for vein centers, and we're coming up for our second accreditation. And I wrote, along with several others, wrote the original document. And even within our own clinic, there are areas that we improved and continue to improve, even going through the accreditation process again. So with that, I'd like to close the didactic part, and I think we have about 10 minutes or so for questions.
Okay, thank you, Dr. Passman. At this time, we will begin the Q&A session. From IAC, I'd like to introduce Laura Humphreys, Director of Accreditation for Vein Center. She will be assisting us with the Q&A session today. Laura, would you like to start us off?
Sure, thanks, Kelly. Dr. Passman, I have a question here. If you had any information about the overusage of phlebectomy or sclerotherapy, do you have any comments on that following ablation?
Yeah, I don't have much on that because it's most of the focus right now is on the ablation side of things. The sclerotherapy, the spider vein treatments, that tends to fall in a different area in that most insurance carriers don't cover it. So because of that, it's receiving a little less attention. Sometimes it's more cash out of pocket. It's a different level of expectation because the patient may not have symptoms, but they just don't like the way the vein looks. So that's a little bit of a different discussion. The phlebectomy is kind of halfway in between, because certainly there are varicose veins that are directly related to the axial reflux and fall in line with patients who need ablation may also need phlebectomy. And then there are some that just have varicose veins who don't need the ablation, but certainly may have painful varicose veins. And again, insurance criteria for just varicose veins and phlebectomy, it's usually not covered unless there is axial reflux. And that also in part is why I think there can be some fraudulent representation of axial reflux, because patients come in with just varicose veins, but their saphenous vein might be normal, but their insurance won't cover the varicose veins. So, we might as well just document that they also need an ablation. So let's do the ablation and we can do the phlebectomy. But that said, I think the ablation really may just be the tip of the iceberg. We just don't have good data on the varicose veins and spider veins.
Okay. Do you feel that venous screenings are a gray area with regards to ethics?
Well, it depends what the purpose of the screening is. If screening is to help public awareness and help identify disease and educate the public, screening can be a very good thing. If the purpose of screening is to find patients to treat with the intent of steering them towards treatment, then I think it could be a negative issue, and certainly can lead to or facilitate, this whole notion of patients getting too many procedures. I actually participated many years ago in the venous screening program through the American Venous Forum, which is still available in some capacities, but it was really meant to be an increased awareness type campaign, and really structured it as such. And having done that, it was a very fruitful thing. So if there's opportunities to screen, I think that's good, but it has to be done really for the right reason.
Okay. I have a question from a technologist. The technologist wants to know, what can she do to protect patients from overablation, over testing, or just, random studies that are obviously not ethically approved. Is there anything a technologist can do to help that?
Well, certainly, I think the quality of the exam, it starts with that, making sure that it's done within an accredited lab and appropriately trained technologist, and then all the components of the exam that need to be done are done properly. I'll give you an example. Some patients come in with a 5-minute ultrasound done somewhere else, just looking at their saphenous vein, and boom, 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 you have reflux, and that's a completely inappropriate test. Mm-hmm. As opposed to the real test, really, you got to get the legs down or stand the patient up, and it takes a good 45 minutes plus or minus to do a proper exam. The ultrasound technologists, where they work, if there's pressure to shortcut the exam or pressure to find reflux where there's no reflux, I think the ultrasound technologist in that scenario or that situation needs to look at where they're working and what's being asked of them, because by proxy, that if they're being asked to do that and they follow that, then they're also stretching the band of their own ethics. And certainly, if there's whistleblower opportunities, mostly with the insurance companies and the state boards of medical examiners. If there are people out there and being pressured to do things that are unethical within that practice, that they can report that practice. At the end, you have to be comfortable with who you are, what you do, and where you're doing it to be ethical.
Right. We have a question about the reference Journal for Vascular Surgery article that you spoke about with the geographic variations. It showed that there was clearly an issue with the South. Do you have any idea why that might be?
I have no idea. I live in the South, and I don't know why that happened or that shows. I would have expected it to be equal across the country. I'm not sure they have a good explanation either, except it is what it is. And I don't know if it's just the practice environments in part of the country facilitate over-utilization. You know, the South has Florida in it, and there's a lot of vein work. A lot of the fraud cases are popping up in Florida. But then again, you know, other parts of the countries have big centers. I mean, California is, you know, and New York and things like that. So I think it was an interesting thing that came up in the study, but it's something that can't really necessarily be explained by the data. You know, I think if anything, it shows that if you live in the South, you might have a higher risk of having more ablations done on you than anywhere else, more for the patient to be aware of that. But in reality, patients should be aware of all of this and ask the appropriate questions.
Okay, do you think that the payers potentially may use the Improving Wisely data to establish an average and maybe limit the number of ablation procedures that they'll cover?
That may be where it's heading. The providers have all this. The carriers have all this data. They've had it a long time, and when you look at the graph there, it's really there's a small percentage of physicians, providers, 5% plus or minus, that are really doing the over-ablation. So if you narrow the curve down, it doesn't take much to get closer to that average. You know, the insurance company will never say you can only do 1.6 ablations per patient, because they're not going to pay for half of an ablation. But whether they limit it at 1 or 2, or probably what the most appropriate thing is, if you need more than 2 ablations, you might have to provide a higher level of documentation to justify it. But the problem with insurance is they see the problem, they know the problem, they do the math, and the quickest way to fix it is to penalize everyone. So the few bad apples makes it harder for everyone else who are trying to do the right thing for our patients. And it's a constant discussion with insurance to try and work through this. And that's why when it comes down to things like having an NCD for varicose veins just in the Medicare population, for instance, and making sure it's a smart thing and it's properly done, and that they have the right stakeholders at the table when they create the policies, that's all important.
Okay, I think we just have time for one more question here. Do you think provider and technologist education on the physics and hemodynamics of the venous system may be a cause for overablation and venous insufficiency ultrasounds being ordered excessively?
I think it depends where they're getting education from. I think it's okay to think about venous disease in our patients. And in fact, if anything, venous disease, if you look at our populations, underserved. There's a lot of focus on the arteries, and for many, many years, people have ignored venous problems. I think part of the education, though, is making sure that the tests are ordered for the right patient and for the right reason. So it's really, not a matter of just ordering the test to go find something to ablate. It's ordering the test because someone has venous findings and venous complaints that might explain their leg pain. Then leads to the next level of investigation. But it's not just, go get the venous ultrasound for the sake of getting the venous ultrasound with the intent of doing the procedure.
Right. Okay, well, I think we're just about out of time. Thank you very much, Dr. Passman. I'm going to turn this back over to Kelly.
Thanks again, everyone. And a very special thank you to Dr. Passman for this presentation today. Please feel free to contact IAC with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of this live session and also be available from the IAC webinar portal for 3 business days. On the left side of the My Account page, you'll click on Webinars, look for the title of this session, The Problem with Endovenous Overablation and Need for Accreditation. Beneath this title, you will click Review Event. On the left, select the Evaluation tab, then click Take Evaluation to complete the survey. Your certificate can then be accessed and printed from the very next screen and any time thereafter through the CE transcript section on the My Account page. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you for joining us today and appreciate your participation.